Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Okay, so I think it's a good time to get started. Hello, everyone, and welcome to this week's edition of Can COVID Speaker Series. Thanks for joining us today. My name is Rosa Staltieri, and I lead the research and evaluations team here at Can COVID. And I have the pleasure of introducing you to this week's speaker, Dr. Christiaan Righolt, who is the lead of the Vaccine and Drug Evaluation Center at the Department of Community Health Sciences at the University of Manitoba. And our title for today is Patterns and Descriptors of COVID-19 in Manitoba. So just a few things to note before we get started. We have saved time at the end of today's presentation for a Q&A session, so please don't be shy to enter in your questions into the events chat, and make sure you do select to everyone when you're doing so. And as always, we will have a brief announcement at the end that we will share. So without further ado, I will hand over the mic virtually to Dr. Righolt. Thanks.
Thank you for the opportunity to speak here about our research. We all know that understanding test patterns is essential to understand incidence rates and numbers that we hear about COVID-19 infections. We also know that testing patterns differ by the reason for testing, asymptomatic screening versus symptomatic testing, and disease patterns can change as well. So before we started on this in the study, there wasn't much detailed data available about the situation in Manitoba. So we examined this for our province, for the entire population of the province between March 2020 and May 2021, and we looked at testing rates, incidence rates, and severity of COVID-19 and its outcomes. Throughout the presentation, I loosely refer to COVID-19 and COVID-19 incidents, but keep in mind that all these mentions specifically mean lab-confirmed COVID-19 infection, and that all public health testing in Manitoba has been done using PCR tests. We used several data sets in this study. Manitoba Health is the provincial insurer, and they provide health insurance to almost all residents in Manitoba, and as part of that, they maintain several central administrative databases. These are routinely collected even before the pandemic, and contain stuff like all hospitalizations, physician visits, etc. During the pandemic, they also maintain several additional COVID-19 specific databases. The first of this is laboratory results, which includes all testing in Manitoba, and it also includes reason for testing as a free text field. We did categorize these as asymptomatic screening, symptomatic testing, and asymptomatic contacts or person in outbreak situation. They also maintain a surveillance database which tracks COVID-19 patients and their outcomes, as well as contact tracing information. And there's also a vaccine registry in which all COVID-19 vaccines provided in Manitoba are registered. We have access to this data, and we use this for several analysis. We start out by just calculating the testing and incidence rates by week, and we also did some regression analysis. We first looked at the descriptors of COVID-19, which people are more vulnerable to it than others, using Cook's proportional hazard models to calculate the odds ratio, or the hazard ratios of these association. And here we started the time at risk at the start of each wave, which I will get to in a second, and ended the time at the end of the wave, or when a person got COVID, or when they lost their Manitoba health coverage. We also, for each patient, looked at the outcomes. We looked at hospitalization, ICU admission, and death, and calculated prevalence ratios using Cox regression with constant time at risk. We first looked at the epidemic timeline, and here we examined the time from March 8, 2020, which was the first case of COVID-19 in Manitoba, and till the end of the data we had available when we did this study, which was the end of May, or actually June 1st. In this graph, you can see the number of tests done over time by week, and there's a gap here. Keep that in mind. The number of cases in the darker gray, and within the cases, how many were hospitalized, were admitted to ICU or died. And the lines are vaccine uptake on the right-hand side as a percentage. And as elsewhere in Canada and Manitoba, the second dose was delayed until the end of May. We were still in the middle of the first dose campaign. Over the last year and a half, we started out with a very small initial wave before a calm summer in Manitoba, until incidents started to increase, until the first wave started in earnest in October, and peaked towards the end of November before it reduced and transitioned into a third wave starting in March. After the graph I'm showing here, incidents reduced, and more recently a fourth wave has started. Restrictions in Manitoba varied over time and are very much in line with what has happened elsewhere in Canada, with gathering sizes, store capacity, etc., limited. One thing I think that is more variable across the country is school openings. In Manitoba, schools opened in September 2020 and remained open until almost the peak of the third wave in May, which was fully open for 12 and under, and some hybrid opening for older kids. To look at the intensity of the pandemic, the testing was massive during the second and the third wave, with about one test per every 2 person years, and the incidence was about one case per 20 person years. We focus on these waves in the remaining of the talk, and in most places I've combined the second and third waves as the relative risks are similar. Manitoba has a few different regions, and when we looked at testing rates, we saw some differences throughout the province. The North had the highest testing rates, both for asymptomatic screening and for symptomatic testing. The North is a largely remote region with about 3/4 Indigenous population. The South had a relatively low testing rate, especially when it came to screening. And this is a region that's agrarian and mostly conservative. The rest of Manitoba includes Winnipeg, the major urban center of Manitoba, and some other larger towns in the province. We stratified the other results by these regions and by reason for testing, and we have a lot of results published in more detail in the paper we just published. I'm just going through some of the highlights here because of the limited time and space on the screen. When we compare younger children, like less than 10-year-olds, in this case, the reference group 30 to 49-year-olds, we see that these children have a relatively high risk of COVID-19 as an asymptomatic contact, or being being asymptomatically in an outbreak setting. There is also an increased risk when screened. So there's asymptomatic screening in the urban areas. The city of Winnipeg and its surrounding bedroom communities are the bulk of the rest of Manitoba. And we saw a decreased hazard ratio for symptomatic positivity. When we looked at income quintiles, neighborhood income quintiles, we saw a gradient. Here I'm just putting a hazard ratio of Q, the highest income quintile compared to the lowest income quintile. And we saw that people residing in low income neighborhoods overall have a higher risk of COVID-19. This risk is most increased in the north and least increased in the south. And we see an especially high increased risk for asymptomatic contacts. When we look at long-term care facilities, I split the results here in the second and the third wave because of the differences between these waves, especially as these groups were the first groups to be vaccinated. In the north, there's a relatively small population and few long-term care facilities, so there were no meaningful estimates. The numbers are as we all know, with the outbreaks we have seen, shockingly high in the second wave, and this is not completely due to increased testing. These residents were tested about 3 to 4 times the rate of the rest of the population. So even their risk of getting COVID is not just due to that. We do see that the third wave, the numbers have improved a lot, and the confidence bouts, as you can see, are pretty wide because of the relatively low number of cases in long-term care facilities in the third wave. Next, I'm switching to outcomes. So this is grouping all the regions together. We're looking at the prevalence ratios by age groups of various outcomes, and we see that for hospitalization, ICU admission, and that there's a strong age gradient in the risk. The older you are, the more at risk you are, which we have seen in other studies as well. Overall, in Manitoba, we saw that 2% of all COVID-19 patients died from the disease, and we saw even in these numbers a marked difference between the second and the third waves. And in Manitoba, as elsewhere, older people were earlier in line to receive the vaccine, which likely explains much of this effect. When we look at income, we see income gradient in the outcomes as well. And keep in mind, these are prevalence ratios after already accounting for people getting the disease. And we see the lower income neighborhood you live in, the higher your risk of each outcome is. So overall, what we saw that young children had a relatively low risk of being asymptomatic positive, and what could have happened, especially because schools remained open for most of the second wave or for the entire second wave and the majority of the third wave, is that there were competing respiratory infections. There was also, in many cases, a requirement to provide a negative test to return to school earlier without a long isolation period. We did note a high risk of being testing positive, when asymptomatic, both when it's screening in a contact or outbreak situation, which seems to suggest that children are more likely to be asymptomatic carriers of the disease. For long-term care residents, we saw a very high risk during the second wave and a much lower risk in the third wave, likely due to them being one of the first recipients of the vaccines as they came out. We also saw that asymptomatic screening rates were close to symptomatic screening rates, and even though there was a massive number of tests done, I don't think there's been many cases. There's been any disease earlier that had that much testing being done. We also realized that testing and screening in particular is not necessarily representative for the population as a whole, and as such, we cannot claim that this provides an estimate of the proportion infected, and we're only seeing the people that actually went for testing in these results. As for Manitoba's regions, we saw an increased risk in Manitoba's north. They have higher testing and incidence rate and a higher positivity rate than other regions. In Manitoba South, we saw low testing combined with high positivity, which could indicate a diagnosis of COVID-19 in this region. And this is also the region with some of the lowest vaccine uptake in Manitoba. We noted that although residents of low-income neighborhoods had a similar testing rate to high-income neighborhoods, they had an increased risk of COVID-19, and once they had COVID-19, they were at an increased risk of having its severe outcomes. And some of the underlying data I wasn't able to talk about in detail here, but this is all presented in a recent paper as well. There's several reasons that might explain these disparities. Low-income residents and other vulnerable people are more likely to live in crowded housing or work in essential jobs, which makes them more likely to be in close proximity to others and impedes their ability to isolate effectively, either as a precaution or when they would have COVID-19. These same people also face barriers to healthcare, and systematic racism could play a role in some of these as well. So overall, we saw that the most marginalized communities were the most vulnerable to COVID-19, especially the residents of Manitoba's north, of low-income neighborhoods and of long-term care facilities, especially in the second wave. We noted the possible underdiagnosis in the southern region of Manitoba, and we also noted that young children were at a higher risk of asymptomatic infection. I want to thank the director of the Vaccine and Drug Evaluation Center, Salah Mahmoud, our staff and students, Gan Zhang, Gurpreet Prabha, Marissa Vera, Krista Wilkinson, and the Manitoba Health Center for Health Policy for making the data available to us. And no endorsement by any one of these results should be inferred. Thank you for your attention.
Thank you so much, Dr. Righolt. It's 4:20, so to our participants, if you have questions, please do enter them into the chat box, and we'll get started. So the first question we have here is, what about the rate of infection or positive tests amongst workers, like staff at the long-term care facilities, healthcare workers in general, or are they reported at all?
So we don't have the denominator information for these people. So in the testing data set, there is a flag for healthcare workers, without there being a distinction like what kind of healthcare workers. But for the denominator, we do not know who works in healthcare facilities or when they work there. So we can't calculate these particular rates.
Thank you. And our next question is, how have predictive models improved for COVID-19 over time, and in what ways can we use data sets to create even more sensitive models now than earlier in the pandemic?
I'm not sure what the question exactly is. I hear so we know that during the pandemic, like, things have shifted, and what we see as well in the second and the third wave between the long-term care facilities, before and after introduction, that this likely needs to be incorporated going forward in predictive models.
Great. And the next question here is, how was contact defined? In Ontario, those wearing face coverings weren't counted, which, well, according to this person, makes no sense. So I wonder if you have any comments on that.
So in this specific case, our three categories are based on the information entered in the laboratory testing data set, which is a free text field. So this basically is self-reported, whether people present with symptoms or not with symptoms, or whether they state they were either in an outbreak situation or were in close contact, as they themselves may have been informed by public health.
Our next question here is, what are the screening scenarios in Manitoba? Can you please maybe describe some of that?
So mostly healthcare workers, to my knowledge. And again, because we based it on a free text field that is mostly self-reported, I don't know how strict the delineation is between asymptomatic screening and asymptomatic contacts, but it was like most of the extensive screening was related to occupation.
Okay, and our next question here is, for determining whether a person was tested positive by PCR, what kind of PCR cycle number was used? Above 30 cycles, the accuracy of testing results is suspect. Was serological studies that tracked antibody levels performed to better assess COVID-19 occurrence? So there's two questions there.
So we just use the provincial databases. So what public health deemed to be a case, we took those as the cases as well. And there was those that were reported positive in the laboratory results were matching the cases in the surveillance database. And I'm not entirely sure what exact cutoff is they used, and whether it remained the exact protocol remained the same during the entire pandemic.
So we have another question here. How fixated should we be on positivity rates? I believe the current rate is about, I think the person corrected, so 5.4% in Manitoba. This would be a worry for people in New York, for example. I remember New York was fixated on the rate not going beyond 3.
Well, there's the positivity rate is one of many indicators to look at, right? There's the absolute number, the number of testing, and the positivity rate only says something about the people that are tested. But if people are not being tested, that's another thing to be concerned about. So it's to really see where you're at, you need to look at all these numbers.
Okay, and we have another one here. Just in response to that, you don't have a denominator for healthcare workers or others. Is it not important to understand the role of workplaces in transmission?
Yes, Yes, it's definitely important. And in some cases, for the contacts, in the free text field, like there is a note that it is a workplace exposure, but not always. So it's not something that not being present in there in that field, we can't infer anything from that. But yes, definitely workplace exposure is a very big factor.
Absolutely. And we have a question here. It might be a little bit difficult, but we'll try to see if you can help answer. Can you compare the patterns of infection in Manitoba to those in the rest of Canada?
I I think one of the differences is the calendar time, and that the pandemic doesn't happen in sync throughout Canada. I do think that many of the predictors are probably going to be the same across different provinces, especially as we see like the most marginalized populations are at highest risk. And I think we have consistently seen that in other studies as well. So I don't think there would be provinces where it would be wildly different. The magnitude of some of these relative risks could be different, of course, but and the more similar the population is to Manitoba, the more similar the results likely are. I could imagine the Maritimes with them having fare generally better, that the predictors might be different from the prairies or some of the larger urban centers in Canada.
Okay. We have a few additional questions before we end today. So the next one here we have is workplace data is more complete elsewhere in Canada. So going back to that, what would it take to improve it in Manitoba?
Well, I don't know how complete it is in the rest of Canada. So I don't know what exact improvements it would require, but to have a registry of everybody's job that would remain up to date, or even if we would want to track healthcare workers, the various health-related employers in Manitoba would all have this data. Would it be possible to link to that? Would it be possible who works which shift somewhere? Probably. It would take obviously energy, time, and money to get all that data and link it to people's personal health information.
Okay, and so just to end off here, this last question, it seems like you had higher levels of positive tests for Indigenous people in northern Manitoba. Is there evidence in most recent data that there is less occurrence of COVID-19 hospitalizations as might be expected with herd immunity?
So we don't actually have individual patients' ethnicity. So we just know this applies to the residents of Manitoba's north, which is predominantly Indigenous, but we don't know whether it individually or based on people's ethnicity, whether we were not able to quantify that. That being said, we haven't looked at the fourth wave now. That's work we're doing, and we're interested in learning those results.
Okay, well, it's 4:30 and I know we have to end sharp with this presentation. So I just want to say on behalf of the CAN COVID team, I'd like to extend our thanks to you, Dr. Righolt, for providing us with some of the experience of COVID-19 in Manitoba. And if there are any additional questions that we couldn't get to today, please email Dr. Righolt, and I'm just sending the email address into the chat box. We just like to announce that our next week's speaker series is on Tuesday from 4 to 4:30 Eastern Time, where we will hear from Andre Picard from the Globe and Mail, and his presentation will be around the COVID-19 pandemic at the intersection of science, media, and policy. And this concludes today's event. Thanks again for joining us, and we'll see you all next week.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCovid or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.